Good afternoon, everyone. Welcome to the session on antimicrobial resistance, the urgent global response. AMR, or antimicrobial resistance, is one of the most urgent global health threats as well as economic challenges of our time. Once easily treatable infections now result in extended disease, expensive hospital stays, and untimely deaths. The WHO, and in particular for those in the investment world, Jim O'Neill, former Goldman Sachs, put together the report for WHO that noted that although there are 1 million deaths per year globally associated with antimicrobial resistance, by 2050, unless something dramatically changes, there will be 10 million, along with trillions of dollars of additional costs encumbered by antibiotic resistance. Beyond the humanitarian aspect of it, antibiotic resistance is a tremendous problem because it threatens all areas of medicine, from routine surgeries to cancer therapies, and maybe especially cancer therapies because so many of those have an impact on the immune system. The crisis isn't just undermining our ability to prevent and control those infections, and it's not just an urgent humanitarian problem, it's an economic challenge and opportunity. And the importance of addressing this has never been greater. It's a special pleasure today to have three outstanding colleagues at the dais with me. First of all, let me introduce Robin Patel, former American Society for Microbiology president and current director of Mayo Clinic's Infectious Disease Research Laboratory. Next to her is our own Dr. Erica Shenoy, who's Chief of Infection Control for Mass General Brigham, and Medical Director of the Emerging Special Pathogens Treatment Center. And next to me is Mr. Kevin Krause, current President and CEO of ArrePath, with extensive experience in actually translating molecules into the market, into practice, as well as in bringing AI and machine learning to the problem. So first, let me ask you, Dr. Patel, as a practicing infectious disease specialist, how would you describe the current state of the problem from your personal experience and perspective?
Thanks, Mike, and thank you for having me here, and thank you to the audience for being here to talk about antimicrobial resistance. First of all, this is a huge challenge. It's a challenge for our patients, for our healthcare providers, and it's a global challenge as well. Mike, you mentioned that some infections really are only treatable with antibiotics. We can think about infective endocarditis. Absent antibiotics, those are basically a death sentence. But we also use antibiotics to enable other life-saving treatments. You mentioned cancer, surgical interventions, some complex surgeries. We need prophylactic antibiotics there. And of course, we use antibiotics for less severe infections than endocarditis, things like pneumonia, skin and soft tissue infection, and so forth. So we really come to rely on them. My experience, well, when I was training in infectious diseases back then, I would prescribe an antibiotic against a certain organism infecting a certain patient, and I would really feel confident that that antibiotic was going to work for that patient. But today, because of antimicrobial resistance, just knowing the organism name, for example, is not enough to know that a particular antibiotic might work because of antimicrobial resistance. Resistance is natural. We were talking before this session about your own research in this area. microbes will adapt to their environment. And so under the selective pressure of antibiotics that we use in clinical practice, they will mutate or they will acquire genes that make them resistant to the antibiotics that they're experiencing, if you will. It's just a natural process. It's nothing short of that. And so in retrospect, we in the medical practice should have anticipated we'd end up in this place with antimicrobial resistance. If you look back, Alexander Fleming actually warned about this. It was obvious it was going to happen, and it's evolving now. It has been evolving for several years, but we're in a worse place. And as you mentioned, it's predicted that it's just going to get worse over time. Antibiotics are easy to use. They're prescribed by any healthcare provider. They're not, they don't need a specialist for their prescription. And their use is widespread because they are so effective. But they're also often used kind of just in case there might be some sort of infection that might respond to them, meaning that they can be overused as well, and that's one of the challenges that we see. But antimicrobial resistance is really here because of both the appropriate as well as the inappropriate use of antibiotics. And these antibiotic-resistant bacteria are spreading in the community as well as in healthcare facilities, both of those, and that's really a challenge. We also use antibiotics outside of medicine, which is maybe something we'll bring up in the discussion later. And this has created a need for new antibiotics. We definitely need new antibiotics, but the minute we bring a new antibiotic to market, that whole cycle of selecting for resistance starts again. And so that's one of the challenges economically, right, is that the drug may have a limited lifespan before we see the same issue, resistance, emerging again. And of course, newer drugs can be associated with higher cost, different kinds of side effects, sometimes the need to administer a drug intravenously as opposed to orally. And so antimicrobial resistance has really changed the way that we practice medicine. The drugs we're using, the way we manage these infections has changed a lot over the years.
Thank you, Dr. Patel. Building on one of your comments, AMR, antimicrobial resistance, can be sort of divided into two parts. The mutational resistance that's the hallmark of tuberculosis, for example, versus the acquired resistance, which occurs in many other staph and many other organisms. Tuberculosis is one of the leading AMR problems globally, but in countries like the U.S., Mass General Brigham, much of the problem occurs in hospitalized patients. Dr. Shenoy, you're in charge of infection control for Mass General Brigham. How do you view the problem of hospital transmission of antibiotic resistance, and what can we do about it?
So thanks for including me, and thanks to for that great introduction, Robin. You set me up. I am a clinician, so I take care of patients, but most of my job is trying to prevent infection transmission in healthcare. And I say healthcare because we tend to think about the hospital, but if we really look at where healthcare is delivered right now, it's a whole spectrum from hospital at home to urgent cares to post-acute cares. And in all of those places, the job of infection control is to prevent transmission from happening. How do we do it? We do it through two mechanisms, and this really plays into the challenges that AMR poses to us. We do surveillance because we're trying to detect whether or not we have transmission happening, and then we institute control measures. And those control measures, especially for AMR, which outside of like tuberculosis, generally we're thinking about transmission through contact, direct or indirect, through devices or surfaces in the healthcare setting. So in order to do that, we have to detect these organisms. And as was mentioned, we have resistance in the community and we have resistance in healthcare. So when someone shows up at our doorstep, we really are blind to what is actually going on and what resistance they may harbor at that time. So we can't introduce those control measures. We can't implement those. So I think what we probably know about AMR potentially is the tip of the iceberg. At the same time, in infection control, we're often trying to figure out where's the signal and where's the noise, because there can be the identification of two organisms with the same name, and maybe they look phenotypically the same, but they're actually not the same organism, and therefore these are independent acquisitions. There's no transmission, nothing to be done specifically to stop transmission from happening in that example. I think where I see the biggest opportunities to really improve on preventing transmission are threefold. One, detection. So we talked a little bit about the diagnostic part of it, mostly in the sense of diagnosing for clinical treatment. But we also need diagnostics for surveillance, rapidly available at the point of entry, and potentially using augmented prediction tools to target who we are testing. Because even though AMR is a very big problem, it is concentrated in individuals with particular risk factors, and we probably could do much better using our targeted diagnostics if we had prediction tools and leveraging EHR data and those sorts of aspects. The second piece is in the design of everything we do in healthcare. So from down to the facilities and where care is delivered to the devices that we use in patients. Those devices are generally reusable, and there's a lot of efforts in the sustainability world to use more and more reusables. When I hear reusable, I think, where's the risk to the patient? Is this something that is able to be cleaned, disinfected, or sterilized, depending on what it is? So we could do better in our medical device design, in our design of the physical environment, to reduce the risk of transmission to our patients of AMR or really any organism. And I think lastly is something that kind of big picture is human factors. Right now, when you were describing, Robin, kind of the choices that we are making around antibiotic use or non-use or the just-in-case kind of theory, the same holds true for the ways that humans are interacting in the healthcare environment that either promotes or reduces the risk of transmission. The physical design, the interaction with our systems, those are all areas that we are challenged with, and we are increasingly challenged because healthcare is getting even more complex. And that sort of cognitive overload on all the people who are trying to work in it really presents a lot of risks from the infection prevention standpoint.
Thank you, Dr. Shenoy. Antibiotics, for reasons Drs. Patel and Shenoy have mentioned, has been one of the treatments that has done the most to extend human lifespan. But in 1991, I believe, Science magazine had a cover calling the antibiotic resistance problem a crisis. That was 1991. Given the crisis and given the problem, Mr. Krause, how come the market isn't flooded with new antibiotics?
That's a great question. Thanks for the opportunity to be here today, and to my panelists and for all of you for attending. So I think it's worth actually defining the problem first, and then we'll talk about the causes of it, because the problem itself is much larger than I think we typically talk about when we think about the economics of antibiotics. So if you look at the last 25 years of sales figures for antibiotics before 2003, or before 2004, so 2003 and earlier, most drugs that were launched in that period did well commercially. They sold enough to keep the drug on the market, or they were commercially successful. And that was largely driven by the fact that there is pretty straightforward translation between preclinical evidence and clinical evidence in this space. So you had drugs that you could de-risk before you brought them to the clinic, and you had straightforward pathways to development. And drugs were launched with comprehensive labels describing all the attributes of the drug. Starting in about 2004, coming out of the key tech investigations and changes at the FDA, followed up by the introduction of antimicrobial stewardship, which we'll get to in a second, we saw a change in how drugs are used. Some for good reasons, some for some limitations I'll talk about in a second. And starting from that point forward, there has not, to my knowledge, been a single antibiotic that has actually made back the money that was invested into it. So I want to be clear about that, because we're not talking from a commercial standpoint about profit. We're actually talking about the magnitude of the loss. Not one antibiotic, to my knowledge, has made its money back that was invested into it. This was defined by the O'Neill report that you mentioned, and I and others have given talks on this. The data point that comes out of the O'Neill report that addresses this situation is that the average antibiotic in 2016, when that work was done, took $1.3 billion to bring to market. It's a very big number. That number is much larger today because the costs of drug development have gone up. And at that time, it was estimated that it would take 23 years to make back the money that was invested into it in the first place. That number has also gone up. And you may know a patent life is 20 years, starting from the time you invent the drug. So you usually have 10 to 12 years of patent life once the drug is approved and on the market. So it's not surprising that we saw a retraction of investment in the space. What ended up happening, though, is everything was pushed to biotech companies that are venture-backed, and venture capitalists are in the business of making money, of course. That's what they do. They invest hoping to get returns. And we saw a whole series of high-profile failures, company failures. There were at least 3 companies I'm aware of that went bankrupt after they had launched their commercial product, one of which I was a senior person at Qiagen. And so the venture world sort of also retracted their investments. So the only thing that's been keeping the R&D pipeline alive are investments from government-based and non-government-based grant-making organizations. So there's a lot, so I don't want to name a whole bunch, but Carbex, BARDA, NIAID, others, PACE, et cetera. And so that's what's been keeping things afloat. Now, when you get to the commercial stage, though, all of that money goes away. There is nothing available to you to support the commercial state. So what drives this change? It's really 4 big things from my estimation. One is that is an inherent feature of antibiotics. They are used for a very short amount of time, and they are reserved. As we heard from Dr. Patel, we don't want to use these drugs if we don't have to. I fully support that. I think antimicrobial stewardship is an incredibly important public health practice, but the math just doesn't add up. You use drugs for 3, 5, 7, 10 days, if you use them at all, and it's also a space where high prices are not accepted. So why are high prices not accepted? Because antibiotics are reimbursed under a bundled patient scheme, or a bundled reimbursement scheme, where the patient's total cost of care is reimbursed under the diagnosis that they were given when they entered the hospital. If you acquire an infection in the hospital, you don't get more money to treat that patient. You're probably working on very thin margins to begin with, so adding $5,000 or $10,000 a day to treat that infection is just not going to make sense for the hospital. That's one issue. The second issue is that over time, we've become more conservative from a regulatory perspective with how we develop drugs. So when we launch products, the labeling that is available to clinicians that describes how to use drugs does not accurately describe the benefits and features of a drug. In the gram-negative space, for example, drugs are now developed through urinary tract infection trials. But the new drugs coming to market really need to be used in more serious infections, but data that is available for those types of infections, if it's available at all, is not allowed to be in the package insert of the drug. So we're not providing the tools and information to clinicians to make decisions on when they should use these drugs. 2 other quick things. The post-marketing requirements for antibiotics exceed $500 million over about 5 years. Pediatric studies, phase 1 PK studies in special patient populations, follow-on efficacy studies, 5 years of surveillance. These things add up, especially when you're selling $10 million a year of your drug. And then last but not least, the manufacturing environment. There are very few places in the world that will manufacture an antibiotic. You're competing with the same slot at a manufacturing site for an oncology product or for anything else. A manufacturer will look at your drug and say, this isn't going to get a lot of usage, you're not going to make a lot of this drug, I'm not going to work with you, and if I do, I'm going to charge a lot of money. So I've been in the situation where I have had drugs that I'm bringing to market that the manufacturing cost for a daily dose exceeds the price that anybody will pay for outside the US by many-fold. So what happens? You just can't bring the drug to that market. So some issues.
Yeah, those are daunting. I saw that resonated with you, Dr. Patel. Do you have additional thoughts on that, or?
I mean, we obviously need new antibiotics, right? That's the challenge with AMR. The other thing I guess we haven't really mentioned is how complex AMR is. There are a myriad of different mechanisms, but also a lot of different kinds of bacteria that we're talking about. You mentioned Mycobacterium tuberculosis, the cause of TB. But there are many, many kinds of bacteria that Dr. Shenoy tracks at MGH and elsewhere, all of which we're concerned about. And when you develop a new antibiotic, it's usually not for all AMR. It's usually fairly targeted. So we have huge needs in the field. But it is challenging, right? Because if we are delivered a new antibiotic, we want to preserve it. So we're not going to use it unless we really, really need it, meaning that's not great for someone trying to sell an antibiotic, but it is the right thing to do from a patient care and societal standpoint. So this is a big challenge. The other thing you mentioned is the investment of governments and similar entities, I think that's been very important. I work with CARBAX, I work with NIAID, with the Antibacterial Resistance Leadership Group, and that investment in helping to bring needed tools for AMR to market, including new antibiotics, is, I think, really helpful. Not that the government's going to do this for every antibiotic, but it definitely has helped the cause to have other investments.
Thanks, good points. Dr. Shenoy, thoughts?
Was just going to highlight that word that came up, antibiotic stewardship. I'm not sure how much the audience knows, but the principle is really about right drug for the right patient, right time, as short a time period as possible. And that seems to go totally against kind of the market forces that are out there. I think an analogy for infection prevention and control that kind of resonates here is you were describing kind of the bundled payment, and that whether you had a perfect procedure, we got your joint replacement and you sailed through and left the hospital, you'll get that same, generally that same payment that were you to have complications from that. And you know, that when you're operating on that tight a margin, kind of everything extra is going to put the facility and I think the ability to offer services to people at risk. In infection prevention and control, we are a cost center. We have no revenues, and therefore a lot of the work that we do is really restricted by what our resources are and the value that we bring. So I was thinking about surgical site infections, for example. Some of the procedures that we do and we take for granted as being kind of routine procedures, hip, knee replacements, even say cardiac surgery, those sort of procedures in a 2050 world could be so much higher risk due to the advent of antimicrobial resistance that the calculus as to who goes for surgery or who is not able to go for surgery could be very different.
Thanks. And let me just add sort of some numbers to this. The reason for antibiotic stewardship and not to use antibiotics, and a new antibiotic until it's absolutely the last thing, is that resistance is a numbers game. The more microbes that are exposed, the more patients that are exposed to an antibiotic, the more likely antibiotic resistance is to arise. And right now, if we look at all the antibiotics that have been developed and the emergence of resistance to those antibiotics, it's about 5 to 8 years before resistance emerges on average. If fewer patients and microbes were exposed, say half, then in theory, the half-life of the antibiotic would double. And so by withholding the antibiotic, we have the utility of that antibiotic for a longer time. And so that's why we can't just throw the new antibiotic at every patient in order to enable the economies of scale. Thank you. Well, let me now turn to and ask, where's the brightness on the horizon? So far it's been gloom and doom, and it has been a challenge. Dr. Patel, let me ask you where you see the promising opportunities ahead of us.
So first of all, I am an optimistic person, so I love to be asked that kind of question. I also spend most of my day either doing research or as a diagnostician. So I develop, deploy, and evaluate the clinical value of advanced diagnostics for infectious diseases. And I think that's my optimistic response to this. And why is that? Well, if we look at diagnostics, 70% of medical decisions are substantially based on the results of diagnostic tests. When I was training in internal medicine a long time ago, and I trained in oncology, I was taught, at least at the institution where I trained, that you would never give chemotherapy to someone unless you knew for sure they had cancer and what type of cancer they had, so that you were giving the right chemotherapeutic agent. But on the infectious disease side, it was very different, because there we frequently saw the empiric prescription of antibiotics. Now, things are a little bit more urgent, but I would say part of the problem was also that we just didn't have very good diagnostics. Antibiotics have been around for a long time, since Fleming, or we can debate maybe before that, but we just didn't have diagnostics. that were suitable to inform the use of antibiotics. And so we came into this culture of empiric use of antibiotics in medicine. And that is going on today. We prescribe them, we don't exactly know what our patients have, we don't know whether they even have a bacterial infection, or if they have a bacterial infection, whether that's the right antibiotic for them. I mean, we can figure it out, but traditionally it's taken some time. But, fortunately, today we are in a diagnostic technology revolution. We're seeing amazing diagnostics that are being delivered or can be delivered into clinical practice. Many of them are here, more are coming. There's a huge amount of activity in this space. And what they can do is they can take us to where we are kind of with oncology. That is, we can know, does this patient actually have an infection? What kind of infection do they have? And if they have a bacterial infection, which antibiotic do they need to be treated? So this, I think, is the way to approach this. I think we should really be moving away where it's possible from the empiric use of antibiotics to more targeted use. There are scenarios where we still have to empirically use antibiotics because patients, are very, very sick and we just don't have time to wait for a diagnostic, or we don't have the right diagnostic to inform that decision. And what this would do is obviously bring more products to market, so we can have a discussion about that because that brings up some of the same challenges with new antibiotics. But what it would do for our patients is it would make sure that only patients who need antibiotics get them, and that those who need antibiotics get the right antibiotic, the antibiotic that they need. And that would decrease the selective pressure on microorganisms to develop new antimicrobial resistance, which would be good for that patient who would have less resistance, less microbiome disturbances or toxicity from drugs that they don't need, but also good for AMR in general, which is really a societal issue. It would just decrease the overall selective pressure. And I'm not just talking about diagnostics that we might use in our hospitals, like replace test A with test B. I think we need better, faster diagnostics, but we also need to think about how we're deploying those diagnostics, the implementation science piece of it, where in their healthcare journey or health journey patients are receiving these diagnostics, because today we have the possibility, sure, of deploying them in hospitals, emergency departments, but also very much closer to patients. Even in their homes. I mean, we saw a lot of remarkable advances on the diagnostic side with the COVID-19 pandemic, right? But this can really be translated to antimicrobial resistance to make a difference and directly inform the use of antibiotics. So I'm optimistic about diagnostics.
Thanks. That seems super intuitive, matching the right drug to the right bug. Dr. Chenoy?
So I'm going to riff a little bit off what you said, Robin. I'm also an optimist in this world, and I'm interested in diagnostics not for the clinical aspect, but for the potential to identify patients at risk for resistance, to be able to target our interventions in terms of isolation or other precautions that we use to prevent transmission, but also to have a world in which we are using all the electronic health data available to us, layered on with diagnostics, including genome sequencing, that allows us to see what is truly going on in our healthcare systems, where the transmission is occurring, and then prevent it from happening in the first place. So I'm an optimist that there's many different fields that are converging, and I'm hopeful that there will be a value, like an actual value to this perceived and accounted for, because if there isn't that value, I don't know how much more it would progress. So that kind of vision might not be something that is immediately quantifiable or reimbursable, because it's not directed at a specific patient the way clinical care might be, but it is kind of an overall benefit to the institution, to the hospitals, to the patients.
Thank you. Important aspect to that. Mr. Krause, from the production, manufacturing, translation perspective, where are the bright spots?
Yeah, no, great question. And thanks for letting me not just end with doom and gloom. There's lots we can do here. So I would say a couple of things. I think first we need to raise awareness, not just amongst the people in this room, but in the broader community. Everybody out there knows what cancer is. Not a lot of people know what AMR is. And there's different reasons for that, and we can debate that. But I think having patient advocacy actually helps. Right? We need to have these conversations and be able to talk through these things, and that changes the hearts and minds of legislatures and other people involved. We also need to recognize, and this has been touched on already, but a lot of the rest of medicine doesn't happen if you don't have antimicrobials. You cannot give a myeloablative procedure without antifungals and antibacterials. All kinds of, any situation where you have compromised immune systems requires antibiotics. And we talk a lot about oncology or other therapeutic areas. We don't talk as much about this area and how it supports and enables that, that area. And I'll come back to that in a second, because I think that is one potential solution to marry people working on those things with commitments to AMR. And then lastly, we need to recognize that we have actually been very fortunate in this country despite the challenges we described. If you go to other parts of the world, it is very possible you will receive, or you will contract an untreatable infection. If you go to South Asia or Southeast Asia, clinicians deal with these things all the time. We look at diseases of conflict. There are pathogens coming out of Ukraine right now that are resistant to every known antibiotic. So it could get a lot worse, right? So we have to have that from the optimistic perspective as well. So how do we solve this? Well, there has been a lot of discussion about pull incentives, which is an economic term for essentially rewards received by companies after a drug is approved. To be honest, I'm not sure how that actually works in practice, because I think the optics of giving $1 billion check to a company when they bring a drug to market are difficult to manage, but also that doesn't solve the problem. That might get you back to baseline, but that doesn't represent profit. We need to solve the underlying issues beyond that. But there are certain pull incentives that could make sense married with other things. My company, as we talked about, is using AI and machine learning to try and come up with completely novel drugs, and we've done that. We have a pipeline filled with antibiotics that are completely novel chemistry. They don't look like anything else, and they go after bacterial targets that haven't been exploited for clinical use previously. So increasing the novelty through AI or other means, I think, can also help substantially. Companies also need to get creative. I think there are opportunities for things like the double bottom line concept, where you have a portion of your company that acts like a nonprofit and plays off of the other part of your company that is highly profitable. This is where you might see an oncology-focused company have a dedication to AMR, not expecting to make profit, but reinvesting some of that revenue into that, that type of work. Another way to sort of think about the double bottom line scenario is thinking about infections where you actually can do well commercially, and again, using that money to support other things. So there are certain types of infections where chronic administration or semi-chronic administration is common. So NTM has been one that's been talked about, non-tuberculous mycobacteria, where patients are treated for several years. There are a few examples there where people have done well commercially, and that money could be reinvested into AMR. And then, I just want to say, in general, this is a solvable problem. This was not a problem up until about 2002, 2003. So we somehow have created this problem. There's different explanations for that, but that means it's fixable because something got in the way. And I always like to point to Project Warp Speed as an example of when we have a serious problem, public-private partnerships can fix anything. And that's probably not true, but in this case, it's another example from the infectious disease world. And I think it's just going to take people being aware of this problem and having the fortitude to do something about it. And I think then we can solve this problem.
Thanks. That reminds me, about 20 years ago, actually, I wrote an essay on antibiotic resistance called Where Darwin Meets Newton. As we push on nature, nature pushes back in an equal force in an opposite direction. And then last year, I updated that to a talk that I gave at the Wyss Institute called Where Darwin Meets Newton, and then they both run headstrong into Adam Smith. And so, and so as you pointed out, Kevin, and implicit in your remarks, Robin and Erica, whether or not diagnostics will be properly reimbursed, that's a barrier. Kevin, in the last minute that we have, what other barriers, or what can we do about barriers to the market?
Yeah, I mean, I think most of the ones I just went through are the big ones. I did actually have better diagnostics written down as well, but I know Dr. Patel covered that. So I think, just in general, understanding how and when an antibiotic can be best used would begin to start to solve this problem.
What are your thoughts on things like push and pull incentives and some of the economic approaches that have been
Yeah,
talked about?
No, it's a great question. I mean, push incentives, as I said before, with groups like Carbex and BARDA and PACE have really saved the industry up to this point, so fully support all of those groups, along with the comments that Dr. Patel made. The pull incentives, talking about these prizes and things, I think that can be challenging, but we can get creative there, right? There's been discussion about priority review vouchers for a future drug. There's different things that could tilt the balance, but in the end, I think if we're going to solve this problem, we have to figure out how to solve the underlying commercial issue and have these other things sort of augment that, whatever that solve is.
Thanks. As one of the challenges, let's say optimistically, we do solve the problem in the U.S. I know, Dr. Shenoy, you deal with people who travel a lot, and it's a global problem, right? How do we expand and solve it for the entire world?
Well, it's certainly a global problem because the bacteria have no concept of our borders. And as you mentioned, traveling in certain parts of the world, a large proportion of us traveling for kind of routine, not too exotic or exciting travel adventures will come back with AMR. And whether or not that manifests itself in an infection or just colonization, and then you get admitted for some other reason and then that's transferred to another person, that is happening right now as we speak. So none of these problems can really be solved for the United States alone. It really is an effort that has to be really undertaken across the world, and why WHO and CDC and others have this as such a high priority. We want people to be able to travel. That's very important for our economy to be able to do that, but when people come back or move between areas, and we haven't even talked about the animal industry, I thought we might touch on that in terms of antibiotic use there, but there is a real threat there to the ability for people to be able to do what they want to do and move around the world if we're not solving this kind of all in sync and in lockstep.
Yeah, thanks. Dr. Patel, in the last couple minutes, Mayo is a wonderful place for, especially for cancer treatment, for advanced surgical procedures, things like that. Are those areas where perhaps the financial wherewithal to conduct the diagnostics that would allow us to match drugs with the problem might first happen, and where we could show the utility of that?
Absolutely. We have performed and continue to perform several implementation science studies where, for example, we'll randomize patients to have an advanced diagnostic or not, and then look at outcomes on the patient side, but also antibiotic utilization, which we think is important in AMR. And then based on those results, we will deploy or not deploy diagnostics in a certain way to help better use antibiotics and improve patient outcomes. I will say that to your question about working globally, I think a lot of what we're learning by some of the research and studies that we're doing, whether it's locally at our institutions or across institutions, can be translated globally, right, on the diagnostic side or on the therapeutic side if drugs can become available in certain areas. So, this problem of AMR, it's very much a global problem for the reasons that we heard, that the microorganisms don't respect borders at all. They move around. But I think we also can learn from each other and deploy some of the tactics globally and also inform the development of maybe innovative diagnostics, but cheaper diagnostics. Sometimes we don't have to have super expensive new diagnostics. We can do things, not always, but sometimes for a really reasonable cost and help inform the better use of antibiotics in the US and globally as well.
Thanks. And in just the last seconds, we haven't touched much on the available molecules that could be antibiotics, but what we can say is there's tremendous excitement in that space and lots of things happening. Here in Boston, we have Kim Lewis with Teixobactin. We have Andy Myers with the total synthesis of macrolides, tetracyclines, other classes of antibiotics. We have Jim Collins with AI-assisted drug design. And this is going on all over the world. So there are great opportunities out there if we can just figure out how to get those to the market. So with that, let me again thank this really wonderful panel of thought leaders in the area. And thank you for your attention.